I was down in every way, emotionally down. That was really hard for me, losing my hair and just feeling like I didn't look like myself at all.
Hi, this is Patrick.
And this is Laura.
And you're listening to This is Cancer.
Brought to you by Siteman Cancer Center at Barnes Jewish Hospital and Washington University School of Medicine in St. Louis. National leaders in cancer. Well, thanks for joining us for our part 2 of our season 2 premiere. We are doing another episode regarding women and what they have to do when it comes to fighting breast cancer, because everyone's story is different, and so many women, their treatment and their surgery and whatever they have to do varies in so many ways. We talked a lot in episode 1 with Melanie and Tamara about the sort of the mental trauma of going through the physical loss of losing your breasts and what the reconstruction felt like. And I think it was really important to be able to discuss that, because with me and the 7 or 8 women I know closely that have been through it, I was able to hear a lot of the same things my own friends and my sister have shared with me.
Right. It's not a one-size-fits-all. Cancer is not a one-size-fits-all. Neither is breast cancer. This person might need 3 or 4 procedures. This person might need 1. This person might need treatment. This one might not. So
it's just so complex, and I'm just really thankful that we were able to have Chelsea on with her Washington University physicians at Siteman, Dr. Katherine Glover-Collins, her surgeon, and Dr. Terence Myckatyn, her plastic surgeon.
I think you may have connected a little bit with Chelsea as well, because she was diagnosed at a young age. She was in her 30s, just like you were. And she also had 3 young children that she had to take care of while she was battling this. So I hope this speaks to some of you out there that are moms that are going through the same thing. And I hope that any of you that have questions about breast cancer in general and treatment and what surgeons or plastic surgeons would recommend that you ask, I think you're gonna get some great info in this episode. So Chelsea, I have been a big advocate of wanting to do this episode because so many women in my life have gone through this. And I'm so glad that you were willing to come share your story, especially the fact that you were diagnosed at a pretty young age.
Yes, yeah.
And still, you were just finishing having your 3rd child when you were diagnosed. Is that correct?
That's correct.
Can you take us back to what was going on at that time and
Sure.
how you found out that you had breast cancer?
Yes, yeah. I had my annual OB visit in March. I think that's just important as a side note to mention, and everything was fine. I just finished nursing my youngest child, who was a year old. And on Father's Day, I'll never forget because it was Father's Day, I felt a lump, a big lump. And I had my husband feel it. He felt it. And sure enough, in the morning, it was still there. And I made an appointment to go see a doctor. And at that appointment, I had my first ever mammogram. I was 37 years old.
And so when you went to go see your gynecologist months before, you probably just had the self-breast exam, or the doctor did the breast exam.
Yes, the doctor examined me, and there was nothing there. And by Father's Day, it felt to me a big lump. I subsequently found out it was actually 2 lumps, but very close together. So it felt like 1 lump. And that's when I first met Dr. Glover-Collins. And honestly, I wasn't concerned at all. The thought never crossed my mind that it would be cancer. I had had a cyst before. I have no family history of cancer, breast or otherwise.
So you find out that this is a cancerous mass and that this is going to have, did you know that you would have to have surgery and chemo?
I did not know. So what happened was the radiologist told me that she was 95% sure that I had cancer on that first visit. That was the day I met Dr. Glover-Collins. And they ended up finding on MRI DCIS in the other breast. So they had found tumors in one side that were fairly large that I had felt. I thought it was 1, but it turned out it was just too big, tumors close together. And they found DCIS in the other breast.
Can I ask real quick, what is DCIS?
So DCIS is an acronym for ductal carcinoma in situ.
Okay.
We don't do lymph nodes and we don't do chemotherapy for the DCIS because technically it's completely within the milk duct. It hasn't escaped yet. like the invasive cancer, which would be your stage 1 through 4 cancers. And so there's no need to look in your lymph nodes for something that's completely encased in the milk ducts.
And so you've got 2 masses in one breast, and then the other, they're finding DCIS. Is that correct? Okay.
And so then at that point, what was the conversation once you got all that information back before surgery? What was that conversation between the two of you?
Well, I think I begged Dr. Glover-Collins to not make me do chemo. Was adamant against chemo. And I think surgery didn't scare me. I was happy just to go ahead and have the surgery. I did not want to do the chemo, mainly because I have 3 young kids. And I couldn't imagine being sick and going through chemo with my kids, who were 1, 4, and 6 at that time. Dr. Glover-Collins referred me to my oncologist, and she said I had to have the chemo. And Dr. Glover-Collins also said I had to have the chemo in order for her to do the surgery that she needed to do. So basically, I had my port put in by Dr. Glover-Collins, and I think a week later, I started my first chemo treatment. And my regimen was 4 drugs every 3 weeks for 5 months, with a projected surgery date around November or December 2022.
When was this all discovered?
Last June 2022.
So when you got the results back with what type of cancer you had and what was in both of your breasts, what was discovered, correct?
Yes.
Then it was no surgery at all until we do chemo first.
So with Chelsea, she had a type of breast cancer called HER2 positive breast cancer. And so you'll look on the internet and you'll see all these things: triple negative, ER positive, hormone receptor positive, HER2 positive, negative, whatever. So hers was HER2 positive, which means that HER2 was overexpressed on her cancer. So she needed a particular drug that blocks HER2. And those 2 drugs are called Herceptin and Perjeta. The thing about HER2, though, or Herceptin and Perjeta is that they don't work well when you just give them to patients. They need the chemotherapy to make the HER2 medicines work. And so when I saw that, I was like, oh, she's not going to like this, but I have to tell her. And actually, I called her on a Friday night.
Yes, I remember.
She had just put her son down, because when I called her first time, she didn't answer. And then I called again, and I had to tell her that she needed chemo and that we needed to put a port in. And the reason for this is that we find that if you have a cancer that needs chemotherapy and you give the chemotherapy up front and you kill off all the cancer cells, you have a much better chance of being a breast cancer survivor story, because we know that we've given you our bazooka, so to speak, and we've killed the cancer. Now, if we give you a bazooka and you still got cancer running around after the bazooka, we have to go back to the drawing board. And so we use the chemotherapy up front as a way to try to figure out, how is this cancer going to behave? Is it going to be a good cancer and die off like it's supposed to? Or is it going to be a stingy cancer and hang around and try to come back and sneak it back up on us early? That was the reason why she had to have the chemo up front. The other reason why we use chemotherapy up front is to try to shrink it. If we can shrink it, we can do smaller surgeries. And I have some women in my office that like, Doc, my breast it makes me, right? It makes me feel like a woman. Do whatever you have to save it. And I'm like, but if I take out half of your breast, it doesn't look like a breast. So I can send you to chemo, and if we can shrink it, I can have a shot at making your breast still look like a breast and still function like a breast. Because if I can do a lumpectomy, then all those problems that women complain about nipple numbness and the chest being numb, those kind of go away, right? There are some larger-breasted women that can tolerate a larger removal of part of their breast than others. And when that happens, we can sometimes employ the plastic surgeons to do what's called an oncoplastic reduction. So maybe I am removing a fourth of the breast or a third of the breast, and it's going to be dented in if I leave it like that. But the plastic surgeon can come in and rearrange the tissue so that we still have a breast shape. You still have your nipple intact. You still have the breast skin envelope. And hopefully we can hide that incision so that it's still 10 years from now when you're saying you're a breast cancer survivor, you don't even see your scar because we've done a good job. That's ultimately my goal always for my patients.
What was chemo like?
It was awful.
As bad as everyone thinks it can be?
Yeah.
You had all the side effects?
It was probably worse than I expected. I guess I'll just share. I had terrible diarrhea. It was brutal. I couldn't eat usually the first week or two of the 3 weeks. And then by week 3, I finally felt better and could eat. But then it would start all over again when I would get chemo that Monday morning. So I lost a lot of weight. I met with a nutritionist. I was put on Ensure. I couldn't keep weight on. And it was also just hard having young kids and having that as a symptom. I couldn't go far. I couldn't get in the car if it was I'd say long drive. I mean, I couldn't go more than 20 minutes, just not knowing what was going to happen. And I can't remember which drug of the 4 that I was on, but it was that was a sure symptom. Mm-hmm. There was no avoiding it.
It was a foregone conclusion. That was
a combination. Mm-hmm. And I will say that she got the worst kind because she's young and we want to keep her here. And so you'll find that most doctors are less willing to compromise on the type of treatments that we give because we want to throw everything at it that we know works because we don't want to take the chance that we misstep. And so, but she got the very standard regimen that we give for people with HER2-positive cancer.
And so you did experience hair loss?
I did. But I was willing to try pretty much anything to try to keep my hair. So I did do the scalp cooling. I did that the whole 5 months. I did the chemo, and it worked to an extent. I probably lost 70% of my hair and kept 30%. But yeah, I lost mainly the hair at the top of my head. I had hair on the sides, but because it was fall and winter, I got away with wearing hats all the time. Towards the end of the chemo, and actually I think after my surgeries, I lost my eyebrows and my eyelashes. That was kind of the final thing to lose. And it was strange. I remember thinking because it wasn't during chemo. They held on mostly during chemo, but it was after, I think just maybe they had had enough.
And you probably were down a lot in weight?
Yes. Yeah. I was the lowest weight I've ever been, I think. Yes. And I was down in every way, emotionally down. That was really hard for me. Losing my hair and just feeling like I didn't look like myself at all. Every time I would shower, it was awful. I mean, I was just clumps of hair. It was everywhere. It was very hard to watch it.
What do you think when you were low on weight and you felt low emotionally?
Yeah.
What do you attribute to like getting you through that? What helped?
Oh gosh. Well, it was really low. It's hard to think even what helped. Probably my kids. At the end of the day, they would make me feel better. Just reading that bedtime story and trying to have that sense of normalcy and doing as much as I could with them. That made me feel better. I also had a lot of family support. My husband, my parents, my in-laws. So I think just having that family support and then at the end of the day, having those little bits of normalcy with the kids, still doing the outings, the pumpkin patches, and the volunteering at their school parties. I still tried to do as much as possible to make things feel normal. But I mean, I've never felt worse. I know I've said that a lot.
It's okay.
But I just kind of thought this will get better eventually. I won't keep feeling like this. And that was the case.
Did you go through a time of like, some of my friends call it PTSD after all they went through?
It still hits me. Yes. And it's when I least expect it. I could have the best day and then I just start thinking about what happened, or something triggers my memory, and I think about whether it's chemo or just feeling sick or the hair loss. And yeah, it is a little bit like PTSD. So, I'm hoping that when I hit the 1 year anniversary from finishing chemo, and then I guess 1 year mark from my surgeries, that will happen less. But it does still hit me.
One of the things that's really important, I try to tell all my patients, if you feel like you need to talk with someone, if you think you need help, that, like I said, there's no defeat in accepting help, be it from just talking to someone or physical help. And so we have those services available through the Siteman Cancer Center.
Yeah, I think it's important to make people understand that this is a really traumatic experience to go through. And I don't think people realize it, and you probably didn't either.
No, I definitely did not.
Dr. Glover-Collins, I want to ask you this because my friends, they either had kids or my one friend was taking care of her dying mother when she was going through this. What percentage of women come to you, if you were to guess, and are more worried about how their cancer is going to affect the people in their life than how it's going to affect them?
Probably 95% of the women that I treat always have to say, well, I'm either taking care of my husband who has dementia, or, I have my grandkids, or I just had a kid. I'm pregnant.
What do you say to them to help them realize that this is really about them?
I mean, my favorite phrase is you have to be here to take care of them. If you're not here, then they don't get you. And in order to keep you here, this is what we have to do. And once that kind of sits in, that helps. The other thing I think that helps women kind of accept the fact that they need treatment is I tell them, your breasts have turned on you. They're trying to kill you. This is a fight for your life. We have to do what we have to do to get you through.
Okay, so Dr. Glover-Collins, you did her breast surgery when it was decided that she should get a double mastectomy. Is that correct?
So I knew that she had a breast cancer gene and that she would want a double mastectomy to reduce risk, and she wanted reconstruction. So in order to try to minimize the number of surgeries that we do, we get plastic surgery involved right off the front so that they can be involved with that surgical procedure from day one.
And Dr. Myckatyn, that's where you come in. And so how were you able to alleviate as many surgeries as possible by working together from the beginning?
Yeah, so when we approach patients, to talk about breast reconstruction, I think the first thing is it's, I think, more involved than they think coming, kind of showing up. And,
Chelsea's nodding along.
Yes, yeah.
And I think that's sort of the first thing. And I think, when most patients, of course, they get diagnosed with a breast cancer, their world is turned upside down. And probably the first time they ever considered a plastic surgeon wasn't for reconstruction, but for cosmetic surgery or like botched on TV or something. And so I think they have a sort of maybe a different preconceived notion coming in. So like a big thing for us is what we call like shared decision making. And so there's a lot to it. So in this case, we're talking about a mastectomy, so removal of the entire breast. And then there's other nuances like, are we going to keep the nipple or not? And that is, how close is the breast cancer to the nipple? What stage of breast cancer is it? How large is the breast? So those are kind of the first things that we think about. And then after that, then it kind of gets to the plastic surgeon. At that point, we're first thinking about, are we doing this as an immediate reconstruction or a delayed reconstruction? It turns out the majority of women that reconstruct do get immediate reconstruction. So we start the process at the time. I think it's important for us to explain that immediate reconstruction means that we start the reconstruction immediately, not that we're finishing it.
And tell the listeners what that means when you say start.
So that means that in the first operation, when that mastectomy or lumpectomy, but usually mastectomy is occurring, the plastic surgeon is involved. Most commonly, we're putting in some type of a spacer like a breast implant or a tissue expander. Not only, sometimes we're putting in the patient's own tissue. But that is the start. And the majority of women get immediate reconstruction. I think a lot of it is for psychological reasons. I think a lot of women feel like this sucks and I am, psychologically, at least I know I'm sort of regaining some of my femininity, some of my appearance and clothing, these types of things immediately. But not everybody thinks the same way, right? So there are certainly a lot of women out there who couldn't be bothered, frankly, and some women that are high risk for medical reasons, sometimes for cancer reasons. It's actually not appropriate to start their reconstruction right away. It turns out that one of the ways that we reduce risk for patients with complications with reconstruction is actually to delay the reconstruction. So there are instances where we think we're saving them a step, but sometimes it's better to back off, not reconstruct, and avoid a complication because down the road, they'll have fewer operations. I tell all our patients that when they come in for a reconstruction, and this is the national average, a woman has 3.6 reconstructive procedures in the first 2 years. And so, yes, there are women that we can get done in 1 or 2 operations. There are some women who've had 10, 11 operations. I'd say on average, most women have 2 or 3.
Chelsea, did you have the spacers put in after your surgery? Did that immediately happen with your reconstruction?
I didn't, although we weren't sure going into the surgery what was going to happen. I remember Dr. Myckatyn told me that he really didn't know. He had to see how everything went during the mastectomy piece. He didn't know if I could tolerate a direct implant or if I had to get an expander. So I consented for both surgeries, and basically when I woke up, I found out that I was able to get a direct implant. I did not get an expander.
Is it accurate to say then that basically your case here was almost best case scenario?
Yes, it was definitely best case scenario. Everything lined up. I think I had a lot of anxiety waiting for the pathology. I think that was probably the scariest part for me, was that in between getting home from the hospital and waiting for Dr. Glover-Collins to call me to tell me if she got all the cancer. I was really focused on that. I also had my mastectomy the week before Christmas. I have 3 young kids, so I was very focused on the surgery, but I was also very distracted with everything else going on in my life. But I was very anxious about those results. I think I would have been happy at that point if I had expanders or if I couldn't save my nipples, if it meant that the cancer was gone.
Dr. Myckatyn, can you explain and describe what those are like a little bit? Because they're not round.
Right. So in terms of the spacers, I think the most common thing that happens when women get a reconstruction, especially immediately, is we put some sort of an internal prosthesis in. And sort of the 2 options are a tissue expander or a breast implant. Analogies I often use is like you have a pillow in a pillowcase. And if all you do is remove that pillow, you have all that case available to put volume back. Now, of course, it's not that simple because that pillowcase may not have very good blood flow to it after a mastectomy because sometimes a patient isn't as healthy. And so essentially what happens is once the mastectomy occurs, if we feel like we can't sort of one-to-one replace that volume or achieve a volume that our patient wants, then we put in a tissue expander. It's like a deflated balloon, which goes in. And the premise is the blood flow to that skin isn't what it was prior to surgery, but we're not going to put in this fully inflated device, so there's not as much pressure on the skin. And then essentially what happens is the patient's body essentially habituates, the blood supply to the skin improves, and then weeks later we can slowly inflate that up so that the skin will tolerate it. However, of course, if we can get that implant in right away, the patient doesn't have to come back in and get fills. We try to get that implant in if we can, but the stars have to align to some extent. But even then, we still may touch that up.
I think y'all should tell them that the tissue expander, it's deflated, so it doesn't always look like a breast when it first goes in. And when they are completely inflated, they can be quite hard.
Yeah, they can be hard. So the tissue expanders actually have hard plastic along the back. And they're designed to stretch. And so, as you learned in physics class, for every action, there's an equal and opposite reaction. So just as that tissue expander is pushing up against the skin to stretch things, it's pushing back on the chest wall. And so it means that it's more uncomfortable. So that is a downside, but it's designed to stretch. And in terms of the shape, it has more of a teardrop shape to it. whereas the breast implants that we use these days are round.
And I think one of the things that is important to note, though, is that plastic surgeons are tending to now put those in front of the muscle to make it a better cosmetic appearance at the final, and it's not as hard or as uncomfortable as it is when you put it underneath the pec, which used to happen quite a bit.
Yeah,
is that right?
Yeah, no, it's true. So nowadays, reconstructions tend to be put in front of the muscle. That's absolutely true. And when we put the reconstructions behind the muscle was tight, and I do think it was more uncomfortable for patients. And when patients would use their arms or flex their muscles, the breast implant would essentially do like a little dance or something. And so we would call that an animation deformity. And so by placing the implant above the muscle, we sort of eliminate some of that. And with folks who had radiation, if the chest muscle got really sort of thick and fibrotic, and that also can cause some problems with the implant. And so, yeah, I do agree, like putting them above the muscle reduces some of those things. It does add some new issues, like there's more ripples with breast implants. And we do find implants kind of slide out of place a little bit more than when we went below the muscle. I think taken together, above is better than below them.
Chelsea, you laughed a little bit when he said rippling. Do you have rippling in your implants?
Yes, I do.
Can you explain to people listening what that means, what that looks like?
I've described it to my friends. It looks like somebody put their hand on my breast and kept it there for a very long time. And I have almost just indents. It's faded a little bit, but like Dr. Myckatyn said, I will have to go, eventually I'll have to have another surgery. Although I will say I'm happy. I'm happy with the way my surgery, how everything looks now. It was very hard getting out of the hospital and seeing everything for the first time. I think I didn't look in the mirror for maybe a week. I think when I finally looked, I was actually surprised, and I think I thought it would be worse. But that also, I should note, I had the skin-sparing, nipple-sparing double mastectomy, and I know that a lot of people can't have that. So for me, it's still my skin and it's still my nipples. So it really doesn't look that different other than the rippling, but that really doesn't bother me that much.
What are some of the biggest questions you get from your patients when they find out they have to have this surgery? What do they want to know the most? Or what do you think you could tell people that are listening what they should know the most?
One of the first things that a lot of people come into my office, they say is, just get them both off because I don't want to ever have to go through this again. And then that's when I put my head down and I say, but nothing I do will ever make that guarantee. Bigger surgery is not better surgery. And so removing both of your breasts still carries a risk that it will come back. And they're like, well, if I don't have breasts, where's it going to come back? I say, on your chest wall. Or worse, somewhere else. So bigger surgery is not better surgery. Not every woman's breast cancer journey is going to be the same. And what we recommend has to do with your cancer. And so you can't go by what your mom, your aunt, your neighbor, your church member, your friend went through because they might not have the same cancer. And treatment changes. The treatment from 10, 15 years ago is not the same thing that we do now. Radiation changes. Medications change. The surgeries that we do change. I think we're always trying to get to that point where we can deliver that personalized medicine to deliver the best possible treatment for the best possible outcomes. And I think that's always the goal.
Dr. Myckatyn, what are some of the most important questions they can ask a plastic surgeon about reconstruction as they're making that decision?
I think that it's not a specific question so much as that they feel that they're getting the information and that they are having sort of a voice in that decision making. I think it's important that the patient knows that the plastic surgeon is engaged in a multidisciplinary team, right? So like has communication with Dr. Glover-Collins or whoever the surgical oncologist is, that plastic surgeon is sort of dialed into the radiation oncologist, the medical oncologist, the geneticist, has sort of those relationships so that they can, essentially forecast a little bit what's going on. I think with reconstruction, there's a lot of sort of contingency thinking, meaning that this is our plan. However, we need this backup plan and we're going to do it this way so that if X happens, we have a great way of getting out of that situation. And I think being sensitive to that. I think also somebody that's honestly like listening to what their goals are, right? Because first of all, not every woman wants a reconstruction. Not every woman wants implants. Not every woman wants their own tissue. So I do think listening and trying to do that. And I do think, honestly, a plastic surgeon that's capable of actually offering all those things, they say if all you have is a hammer, then everything is a nail. And so I think being able to offer a breadth of options is super important as well.
This is going to air during Breast Cancer Awareness Month. What would be your parting message to anyone listening? What can you say to women that are trying to manage it all, which is a lot of women these days?
Right. Well, you can't manage it all. I definitely didn't. I had that support on both sides. I had my parents helping daily, and I had my in-laws helping daily. I also had friends, my kids' friends' parents that would help with transportation and getting to my kids' places when I couldn't. I definitely did not manage it all. I feel like for the first time now, it's now been about a year from chemo starting, that I'm kind of getting back into my normal routine. I think that pretty much everything I let slide for about a year. It's not that I gave up, but I couldn't devote my attention to a lot of things.
I think it underscores, too, that for the people who think they can do it all by themselves, that there is no defeat in letting someone help you. And you have to let people in. You can't assume that people won't be able to rise to the occasion, because you'll be surprised with what other people can do when they are presented with the challenge of helping the people that they love.
And what they want to do.
Exactly.
Well, Dr. Myckatyn, Dr. Glover-Collins, and Chelsea, thank you so much for being here and giving this great information, and Chelsea for sharing your story. I'm wishing you lots of things to celebrate at the end of this year.
Thank you.
Patrick, you know how important this was to me to talk about this, and I'm so grateful that Chelsea and Melanie and Tamara were willing to come on and talk about what they really had to go through mentally and physically to beat breast cancer. And I have so much respect for every woman out there that is fighting the good fight and doing what they have to do to be alive for their family and their friends. So I just want to thank them for coming on, and I really want to thank Dr. Myckatyn and Dr. Glover-Collins for coming and being honest about how they treat their patients and what advice they would give to everyone else. I just think everyone on part 1 and 2 of the season premiere was amazing.
Yeah, everybody on this episode was incredible. And if you haven't had a chance to listen to part 1 of this episode, please go back and listen to it now, because Tamara and Melanie's story is just as compelling as Chelsea's. And I would just love to take this opportunity to remind everybody out there the importance of early screening, in this case especially women with breast cancer, because it is the best chance of survival.
Thanks for listening to This is Cancer, brought to you in partnership with Siteman Cancer Center at Barnes Jewish Hospital and Washington University School of Medicine in St. Louis, national leaders in cancer.
For more information on Siteman Cancer Center, go to siteman.wustl.edu and be sure to leave us a review and like and subscribe wherever you listen to podcasts.